Why did you choose to become an endocrinologist?
Actually, I had no real fascination for endocrinology.
It's the usual starting salary for an endocrinologist.
So anywhere between 2 and 3 would be a good starting point. Even 2 lakhs people start off with.
But then how did you and why did you choose to be in a corporate setup like this big hospital?
Ultimately, in every corporate hospital, you are getting paid what you generate.
And sir, when did this Padma Bhushan and B.C. Roy award came into your career?
I got this, I worked, and therefore I got the Padma Bhushan. I did something. I had no idea I'm going to get the Padma Bhushan.
Sir, can diabetes be reversed as a lot of people on social media are claiming?
So yes, diabetes can be reversed in some people.
And sir, अभी young medicos पे residents पे especially बहुत pressure है to publish.
There you can be a co-author. Never
Right.
try to be a co-author as a free gift.
Sir, how do you define success?
Success to me means you're doing what you want to do and enjoying it. Enjoying the process is very important.
His father is diabetic, his mother is diabetic. Now he doesn't want diabetes. Can he defeat genetics?
So, as a very cliched sort of statement, that genes load the gun, but lifestyle pulls the trigger.
Hello everyone, welcome to Delli Docs, जहाँ white coat सिर्फ कहानी की शुरुआत है. Our today's guest, Dr. Ambrish Mithal, has a very special place in my heart because he's the one who has checked every box in the bucket list of all Medicos. He has gone even far beyond it. He's the chairperson and head of diabetes and endocrinology at the Max Group of Hospitals. He received Padma Bhushan Award, which is the third highest civilian award after Bharat Ratna and Padma Vibhushan. And do you know who else got it? MS Dhoni for his contributions in sports. His researches have 15,000 citations. He has shown the world that vitamin D deficiency exists and is a problem even before it was a buzzword, like in 1990s. He brought the first DEXA machine, the bone density machine, to India. He is the force behind the fortification of milk with vitamin D, iodine salt. He is the one who showed the orthopedicians and endocrinologists alike that diabetes causes bone brittleness. It makes the bone weak, it breaks them, it causes bone and joint pain, which no one knew about. So guys, the list is too long. Let's quickly dive into the podcast and talk with Dr. Ambrish Mithal, how he did that and how we can do this as well. Thank you, sir. Thank you for coming.
Thank you for inviting me.
You are an endocrinologist.
Yes.
How did you choose it, or why did you choose to become an endocrinologist?
Well, I did my MBBS and MD from UP, from Kanpur Medical College.
Ji, sir.
And the logical path in UP at that time was probably all over India. This is like 1984 I'm talking about.
Okay.
Was to do cardiology or neurology. So I was sure I didn't want to remain in MD medicine. I wanted to do some specialization.
उस time था sir super specialization
Cardio
का
and
trend.
neuro were well established.
Okay.
Super specialties in UP as well as everywhere. So everyone, it was a sort of set track. You finish your MD, and if you're considered one of the, better students, you would go for one of these. Either DM in neurology, DM in cardiology, especially cardiology.
Okay.
So actually, I had no real fascination for endocrinology.
Okay.
So, but I did not want to do cardiology or neurology because and not that they didn't interest me, but because I thought everyone's doing the same thing. I don't want to do cardiology, neurology. Let me do something different. And the most different branch that appeared was endocrinology, because even gastro and nephro were beginning to make their mark, but there was very little endocrinology.
Sir, when did this start? DM in, if you remember, DM in endocrinology.
So DM in endocrinology in India started in the 70s in PGI Chandigarh.
Okay.
But also it started a little later in BHU. But at AIMS, the actual thrust for the whole program started after I joined. So 1984 is when I joined the Department of Endocrinology at AIMS.
Right.
As a research officer, it was called. Nothing officer about it, but they call it research officer. And 85 is when DM started. So I was the first sort of batch of 2 DM students from AIMS.
Wow.
So I chose endocrinology because it seemed different. Of course, my MD thesis was on diabetes, but I really can't say I was enamored by diabetes and determined to do endocrinology. More or less by chance, you know.
And sir, uske baad your career graph has grown, we all know, to really big heights. You have achieved international recognition with multiple rewards and awards. So मुझे जो पूछना है वो है कि जब बीच में did you feel helpless? Were there times when nothing was going right in your career and you did not know how to cope with it? Then how did you cope with it and overcome this?
Yes, certainly there have been periods like that. So, for example, even in 1984, when I wanted to do endocrinology, there was no course, there was no DM program. So I went to AIMS, and I really didn't know what to do because I had given up cardiology DM, and was
Right.
just came to Delhi with nothing. So and I went and met the professors there, and they said all we have is a research job. As I told you, research officer, which means you have to travel to all the remote parts of UP, Bihar, Assam, etc., collect urine and blood samples for goiter, the national goiter program.
Okay.
So it was the iodine deficiency program. Now, at that point, I didn't know what I'm doing. I'm a hard sort of clinician. That's my love. And suddenly I was told that you can't do any real clinical work. You can hang on there, you can attend the rounds, but you can't be given responsibility because you're you're in the research track.
Okay.
So it was a very tough period to take a call.
And this lasted for
almost a year, 10 months. So when people say I did this and I did that, basically I was very lucky but only thing I did was I said I'll still join endocrinology because I'm determined to do it. And then what happened was that I was lucky because the DM program started and there was an open selection. I was lucky I got selected. I was the only candidate in the open seat. There was one seat.
This helped. This 1 year association with AIMS. This helped.
It helped because I got familiar with the subject.
Right.
I knew very little endocrinology as an MD student. And then so that was one period when I really thought, and even all the family was very supportive. They didn't know what I'm doing. I mean, why would I not take a regular, like everybody else, do a DM in cardiology, take a job or go into practice, whatever. Anyway, that was one very difficult period, okay? Because there was no housing. When you're not in the clinical track, there's no housing.
Right.
So you're staying under someone else's name in Ayurveda Nagar. It was a tough period, okay?
And then, public health.
And then the importance of this 10 months in my life is huge because when I traveled to these places, I realized the impact that iodine deficiency was having on our country. And when I saw village after village of retarded children, physically and mentally, simply because they were not getting enough iodine. Their mothers are not getting enough iodine. So that actually struck a strong chord in me. And while I was the leg person, the lowest person in that, doing the leg work, it stood with me forever. It stayed with me forever.
Okay.
That anything that we do in our country should have a little bit of public health importance, implication, because you can help millions directly. Right. So that's how I got. That is one area when it was difficult. The other part in my life, again, was when I moved to Delhi. So both times my movement from Lucknow to Delhi was tough. The second time was when I was doing very well in SGPGI, Sanjay Gandhi PGI. I was additional professor there, heading the clinical unit. I was, I had DM students. I was external examiner for all the countries' institutes.
Okay.
I was, at the top of my game, I think.
Which year was this?
This is I was 40 years old. So 1998 December, 41. Yeah. So everyone again thought I'm mad because I had no problem in SGPGI. To say my boss was chasing me or the institute was bothering me is all lies. I was very comfortable. It's my hometown, Lucknow.
Okay.
I knew everybody. I was doing very well. I had lovely students. Everything was great. I was publishing. I was in the national field, well known, even though I was one of the sort of youngest at that time. But certain, an itch, you can say, that ये अभी बहुत कर लिया, अभी कुछ और करना चाहिए.
तो फिर एम्स का
तो फिर 40 साल के एज पे then I took the plunge to Apollo.
Okay.
Private, straight. So about 10 years in SGPGI.
Right.
Setting up the DM program there.
Right. Got it, sir.
Loved the field work I did there in fluorosis. Really
Okay.
enjoyed that. That got me a lot of international recognition. And that made bone mineral my main field. But anyway, that's separate. The main thing is that the second stressful point was here, because you're a professor or heading a teaching program and you imagine, the environment, and suddenly you're thrust into a state of practice where you see one patient a day or two patients a day. And you have a room for 4 hours and you're thrown out at 4 hours if someone comes after 4 hours.
Oh, this was in Delhi, Apollo.
In Apollo, yeah. I mean, Apollo was very nice to me, but that's their system.
Right.
So it was very traumatic. Again, you were really comfortable, campus housing, everyone happy, and suddenly you're on the road again.
Right.
So, but I thought I was at some level determined to show that I can succeed in practice. Everyone thought, you're an academic, why are you going into practice? So I said, वो तो हो गया, अभी कुछ और नया करके देखते हैं. Just that.
मैम ने या किसी ने अपोज नहीं किया?
Yes, that's a separate story. She had a well-established practice in Lucknow. She's an ophthalmologist, my wife Ranjana.
Okay.
So, whatever. So somehow...
And sir, when did this Padma Bhushan and B.C. Roy award came into your career?
So I think these came much later. I did, as I said, 10 years in Apollo, and then about 10 and a half or whatever. And then I moved to Medanta. And the thing I tried to do continuously, despite being in full-time practice, was to continue my engagement with academics in some form or the other, particularly in public health issues.
Okay.
And so I was, of course, very keen that endocrinology gets its due recognition and space everywhere, in corporate, in private, in teaching. And I was also very keen that bone mineral get recognition, because when I was at SGPGI, we set up the first bone densitometer in India. The first DEXA system was not in Delhi or Chennai or Bombay. It was in Lucknow in SGPGI.
Okay.
And we were the first to start measuring bone densities in India and then try to set up some norms for India and all that.
Okay.
So this is how it happened. So that whole course of being among the first in endocrinology, then being the first to start bone densitometry measurements, then among the first to establish vitamin D deficiency, and then moving on from that to the public health aspect of it, working with the FSSAI to advise them on fortification of milk with vitamin D.
Okay.
So all that was bearing fruit by 2015. So that stream is what got me recognition. For B.C. Roy, it was development of specialty like endocrinology.
Right.
And for the Padma Bhushan, which of course, I don't know, they never say, but the citation definitely mentions about vitamin D as a concept from beginning till like fortification.
Sir, what do these honors mean to you? Like, these are highest honors, I think, for a doctor. Sir, what do they mean to you right now?
So I have a single line formula for awards and honors.
Okay.
That is, I won't chase them and I'll not refuse them.
Right.
So they come. It's one of those things. You cannot work towards getting these awards and honors. These are not achievements. These are recognitions based on someone else's understanding of your work. So what have you done? You've done what you could. There's no set criterion for any of these.
So you cannot make Padma Bhushan your goal and work towards it.
No way. No.
You have to work in your field, excel, and then...
If people feel the impact or, and they feel that you're one of those who has contributed, that's your luck. That's your luck. And the field you choose and the time when you choose it, everything matters. Others may have contributed more at a different time and not gotten any such award. So a lot of it is how things fall in place. We shouldn't think that, I got this, I worked, and therefore I got the Padma Bhushan, I did something. I had no idea I'm going to get the Padma Bhushan.
Right.
So B.C. Roy Award, one could still think at the back of one's mind that endocrinology development you've seen from infancy. So, There is a category for specialty development. So
Okay.
maybe at some point somebody will recognize it, because a lot of peers were also getting it. Although I think that's the most important award. Again,
B.C.
B.C.
Roy.
Roy, because it's a peer evaluation.
Okay. Peers evaluate
Yes, for B.C. Roy.
Okay.
So that's important. And of course, the Padma Bhushan. So I don't think it'll be very foolish of someone to work towards awards. It can be exceedingly frustrating. You may achieve a lot, but you don't get the award and you feel frustrated all your life.
Sir, being in a city like Delhi, did that make a difference to achieve the success you have achieved? Like, choice of city is also important, because you mentioned you have changed cities twice.
Yes.
And not an easy.
So it's not easy to change cities. So, metros give you a bigger canvas. There's no doubt about that. So the impact of what you do at a national level is definitely higher if you do it from a city like Delhi.
Right.
So people from middle-sized towns, people from Lucknow have had big impact on the national scene, but it takes a little bit more. A little bit more. So undoubtedly, if, again, I'm not talking of practice. I'm talking of having an impact on the specialty. It does make a difference if you're in a bigger city, or if you're in academics, which institute are you working in? It makes a huge difference. So if you're going to be in full-time academics, for example, you need to be sure that you're working in an institute which is conducive to that and which is already sort of getting there in the national scene. If you're working in some, remote place and in an institution, an organization which is not well recognized, you may still make it, but it makes it harder.
सर, जो यंग डॉक्टर्स के लिए आप एडवाइसेस दे रहे हैं उसमें एक बहुत ही मेजर फैक्टर है सोशल मीडिया. एक तो एडवाइसेस ऑन सोशल मीडिया विच इज़ अ कम्प्लीटली सेपरेट टॉपिक, बट एज सच फॉर डॉक्टर्स, how important it is at every stage.
So maybe I'm not well qualified to answer that because I'm still an old-fashioned social media person, but I am on social media.
Right.
I think I have 50,000 followers on Twitter or something, and it's okay. But I started doing social media only for fun. Okay. Just ऐसे ही देखे क्या है kind of thing. Many years ago. So for example, I use Instagram for just posting photographs. That is my stress busting. But whatever medical things I talk about are on Twitter, or X as it is called now.
Right.
Now, I think that in the present day and age, you cannot escape the importance of social media. So anyone saying that I will stay away, who's starting his career now, is not a good idea. I think to be visible and to be seen, it is good to be on social media. But there are certain norms you have to follow.
Okay.
I think. Those are my norms. You may have different ones again.
Yes,
So number one is you should never sell yourself on social media. Don't say, I'm the best, come to me, I'll give you the best this thing, best care, etc. I think that is, for me, old-fashioned, is sort of undermining your dignity. I would say, well, these are the best things to do for diabetes. These are the things you can do to save your knees, and leave it at that. These are the best things you can do for your heart. How should you manage your heart during winter? Just give subject information, what people want. But this may be old-fashioned, and others who are straight away advertising. I may give statistics. I may say, I'm okay with surgeons who say, today we completed our 1,000th knee replacement. That's all right. And then if their results are documented and published, I would share them. That fortunately for us, 84% are walking normally, and there was 1%. So then that has to be documented. It can't be loose talk. All our patients come on a stretcher and go out running is not a good way to deal with it. So one, information, authentic information on social media is very helpful, and we should all be part of that campaign to provide authentic information. And you realize that if you're doing that, you will attract more and more people to your social media accounts. If you start selling things, you may attract people initially, but it won't last. Your respect, your voice will not have credence. If you make those who are respected, one tweet or one post on X gets so many calls from people who matter that, is that correct? Is COVID really coming back, you think? Rather than someone who's making... So, yes, social media, yes. No politics. Absolutely. For doctors. And give information and give data, if you will. But don't use adjectives like I'm the greatest. At least
sensational content se bhi,
that's what I believe, but I may be wrong. Others may have much better success, but I'm okay with this.
Unfortunately, sir, sensational content ही ज़्यादा है.
Yes.
That's the fact.
So वो और लोग को करने दो यार, हम लोग doctors हैं ना. I mean, we are not sort of, we should maintain a certain level of dignity.
Sir, how do you define success today after having achieved success?
So I don't know if I have achieved success.
Okay.
But that is very subjective. But if we were to say, yes, I'm happy with the way it's gone, and I hope to be able to contribute in the remaining years of my professional career, I don't think you can define success as a point. You can't say, today I'm successful, yesterday I was not successful. I think success to me, and everyone has a different definition. So you may have your completely different definition. Success to me means you're doing what you want to do and enjoying it. Enjoying the process is very important. And then getting recognition or appreciation for it. If you are, as I said, working towards a recognition alone, it's not success. I don't think so, at least. Or if you don't enjoy the path and you're looking only at the goal, it won't work. Because the path will be so strenuous that you will get fed up. You have to enjoy. You have to enjoy your work and work towards it. Try to be among the best. You can never say, I don't believe in he is the best. Among the best or among the better people in your field, whatever it is. And if you're enjoying that and people are appreciating that, I think that is success. Now, why I'm saying this is very subjective, because others may not want any people's appreciation. There are very evolved people who would say that I just am happy with doing this. I don't want anyone to acknowledge or appreciate me. But also, for me, it matters.
I also think that, like you said, enjoyment is important because motivation will only take you to some point.
Yes.
Unless you really enjoy it, तो आगे तो नहीं कर पाएंगे otherwise.
See, जब हम लोग मेडिसिन ज्वाइन करते हैं, मैंने 1975 में मेडिकल स्कूल ज्वाइन किया था. सो ये तो सच बात है. आप कितना भी उसको आजकल ये बैलेंस और इसमें सब छुपा लो, बट द फैक्ट इज कि मेडिसिन ज्वाइन करते हो तो 24/7 योर लाइफ इज गॉन.
यू आर मैरिड फर्स्ट टू द मेडिसिन एंड देन
वो कुछ कर नहीं सकते आप. ये प्रोफेशन ऐसा है. Maybe at some stage you can achieve some, semblance of balance. But so I think that kind of thing has to be there. We have to understand this from the beginning, that this is a 24/7 job. And if you don't enjoy 24/7, then you can't last. No? How will you last? You'll fall by the wayside.
Right.
So enjoying the path, enjoying the process is very, very important, not just the goal.
Sir, talking about academic work and publications, sir, I have seen you have multiple articles who have achieved global recognition, and one in particular has achieved citations more than 2,300, I think, around. And for those who don't know, citations in academic world is very similar to the mentions in social media, I think, sir. So I think this must be around 1 million or maybe more mentions and likes. So this is one question. And then you also have a publication in Lancet.
Yeah.
So sir, thoda sa uske baare mein batao.
So I think, my best academic phase was when I was in SGPGI.
Okay.
No question about that. Although these publications are much after that. So when you're in a teaching college, in India, even there you have to give a lot to clinical work. But you can divide your time to maybe 50% clinical 50% academic or 60-40. You have the freedom to do that. People don't realize there's a lot of freedom in academia, right? So you can do that I will, do this much. I'll give so much time to academic work, which includes teaching, research. So you can say I'll do 60% clinical, 20% research, 20% teaching. You can mix it up, even if you don't have it as tightly defined as Americans do, but you would have it like that. But when you're in practice, it is 100-0 almost.
Right.
So what I have done consistently, tried to do, and I'm not saying you should do it. It's not mandatory to do any academics when you are in practice. I have tried to keep 20% of my time for non-practice purposes, which means either reading or writing or reviews or meta-analysis or studies. And then when you have DNB students, because in all three places where I've worked, I've had DNB programs started. There were none existing in Apollo or in Vedanta or here. Okay. So then you have students, and then you can guide them, and you can get you can choose good topics and get good publications. Right. So my recognition in this field has been because probably I chose the right topics. Again, topics of interest to a lot of people, topics that gain mileage and of interest to me. You have to modify your research based on your environment. Okay. When I was at Brigham and Women's Hospital, Harvard Medical School, in the early 90s, where I did molecular biology of calcium sensing and all that. Okay. That was pure laboratory work. But I realized at the end of 1.5 years or so, even at the end of 1 year, that I enjoy this, but I don't enjoy the process. I enjoy the publication coming out of it. So I said I'm going to go back to SGPGI and do more clinical work. So once you choose your area of research broadly in that area. Now in SGPGI, I did some basic, but not the way I was doing at Harvard. I got into fluoride and vitamin D field work, which was relevant for India. Right? And touchwood, God was kind. I got a lot of recognition for that work in the 90s. When I moved to Apollo and then Vedanta and now Max, I quickly realized I can't do any field work anymore. I really can't, because my primary job is to see patients. Right. So if I had struggled with trying to do field studies, I would have struggled. So again, modified. So then I started direct clinical research, following up patients with one treatment versus the other, those kind of things, profiling patients, all those things. But I continued to have a little inclination towards the field that attracted me. That was, for example, vitamin D or let's say diabetes. And I kept churning out something in that area all the time. And it all accumulates. And therefore won this global vitamin D status paper for the IOF, which was it's actually a position paper or review kind of thing, but it drew attention to vitamin D again globally. So I just thought this is a good time, and I was representing India in the IOF for forever.
So do you also decide the
IOF is the International Osteoporosis Foundation. Sorry, yeah.
Right. So do you also decide the topic of research based on कौन से जर्नल में ये पब्लिश होगा या this will have a bigger impact? For example, if I say like मैंने अगर AC joint पे करता हूँ जैसे मैं, so I know that this won't be as big as if I do some research on public health. So although I might want to do on AC joint, so do you think that should hamper the decision?
Targeting a journal, Naman, is very difficult when you start your project. That you can only do when you're writing. Only then you figure out where this can go. But targeting an area, you can certainly do that. As I myself said, I realized that vitamin D interests me a lot. And this is the time to do it. It is a global problem. It's a public health problem. If I do it well, this will work. So like that. Empagliflozin, the Lancet one. It's the upcoming drug. Fantastic. I'll be part of this large study and, one of the main authors of that. So the idea is that you should not deviate from your primary interest.
Enjoy the process.
But enjoy the process and modify the research. So it becomes very different as you go along. I mean, it could. Some may want to, if I had, for example, remained in SGPGI, I would have kept working on more basic stuff in the same area and published 10 times more papers, I'm sure. And I've had much greater academic recognition than I have right now. I'm glad and I'm happy that I've got enough recognition. But quite clearly, if I was doing pure academia, it would have been different. No? So you're foolish to say that even though I'm now in practice and I am publishing, what great thing would I have done in an academic institute? That's wrong. In an academic institute, you would have achieved more in academics. So you have to see what you're looking at.
एंड सर अभी यंग मेडिकोस पे रेजिडेंट्स पे स्पेशली बहुत प्रेशर है टू पब्लिश फॉर सीवी एंड आई फील द प्रेशर इज टू मच because everybody is running after and then the quality is going down and the kind of journals, if I'm allowed to say Chinese journals, sir, वो तो आप सर इस पे क्या कमेंट करोगे?
देखो, पब्लिकेशन तो इम्पोर्टेंट है नंबर 1, लेकिन थर्ड रेट पब्लिकेशन का कोई फ़ायदा नहीं है. तो ये जो रोज़ ईमेल पे आते रहते हैं कि हमारे साथ पब्लिश करो ये वो, वी आर ऑनर्ड बाय योर वर्क और सम नॉनसेंस, इससे कुछ, बिकॉज दोज हू गोइंग टू असेस यू आल्सो नो दैट ना. आप सोच रहे हो कि मैंने छाप दिया, उसके कोई वैल्यू नहीं है, बिकॉज जो पढ़ता है वगैरह ये क्या है, दिस इज नॉट. सो यू हैव टू डू अ सर्टन लेवल. उसमें 2 एंगल्स होने चाहिए. एक स्टडी आपकी हमेशा अपनी चलनी चाहिए जो कुछ solid, randomized clinical trial or something that is really solid research, which will ultimately go to a good journal. More importantly, will contribute some authentic information. But you can also be part of other studies where you can help people and be involved either in the planning or the execution or the writing. There you can be a co-author. Never try to be a co-author as a free gift. Okay, please stay away from that temptation. But wherever you can contact, that's one. The third is that sometimes our mentors know better than us. Definitely. And many times I have seen my young colleagues will say, इसमें क्या है सर, इसमें कोई नई बात नहीं है, ये नहीं छपेगा, तुम लिख दो यार, लिख तो दो, देखते हैं. Because they have the wisdom or the experience to see कि ये इसमें छपने लायक, it may not be a Lancet paper, but this will go to a reasonable journal. Right. So I think ये combination करना पड़ता है. But don't go for third-rate journals. Don't compromise on your primary study or studies if what you're doing. And you can be part of others and be guided by your mentors.
Sir, आपकी main research रही है vitamin D पे, if I'm thinking right. And sir, DEXA भी establish किया, and I think which is half of my practice as an orthopedician also. Sir, India में there is sunlight, sunshine around the year. Please थोड़ा सा explain करो, why is vitamin D deficiency so prevalent and क्या problems हो रही हैं? Some light on it.
So vitamin D deficiency is widely prevalent in India. Not everywhere, but in most parts of India. There are multiple reasons. As you know, because we have darker skin, we require higher sunlight exposure, longer sunlight exposure.
Right.
Now, with urbanization, we've all moved indoors. Now, for example, doctors have zero sunlight exposure. Our first study was on doctors and we found levels of vitamin D below 5 nanogram per ml.
Okay.
Because, radiologists, anesthesiologists will be zero. So,
absolutely.
So think of the IT guys, again the same thing. Think of so many professions which are indoor bound now, which are living in air-conditioned environments. So for urban, white-collar jobs, sunlight exposure is very minimal. So the only people who have good vitamin D levels in metros like these are, the people who live on the street, the rickshaw pullers and others. That's been shown in studies. So they have good security forces. They have good D levels. But there is a catch there also. The catch there is that the abysmal air quality, the air pollution that is so rampant, especially in our metros, especially in the north, it scatters the UV rays. So in Delhi, even if you were to go in the winter sun, you'll probably make very little vitamin D. Studies have shown that.
Is there a specific time of the day?
Yes, 12 to 3 for example.
12 to 3. Okay.
But वो scatter हो जाता है. The UV beta rays don't reach your skin.
Okay.
Because of the suspended particles. So there are many reasons why Indians have D deficiency, and fortification has only just started.
Right.
And we hope that will reduce at least the severity of D deficiency in India.
So everyone should take supplements, or
So
at least consult a doctor.
we should look at, when we buy our milk and all, we should try and get fortified milk. Now it's available.
Okay.
Number one, that is the bottom line. But in winter months, if you're living in Delhi, there is absolutely no harm in taking supplements. 1,000 to 2,000 units a day. Our studies have shown that 2,000 IU per day is sufficient. You'll never go into toxic range and never be deficient.
Okay.
And a daily dose is better than a monthly or intermittent dose. That's been shown now. Traditionally, we all gave, intermittent doses. From 40 years, I've been doing that. For last 2-3 years, we've changed that
Once
practice.
weekly.
Well, once weekly initially, that is still okay. And then once a month for maintenance, once a year large doses, ये सब होता है. तो उससे अभी डेटा यही है कि जो अब हम डेली देते हैं, there's less fluctuation.
Okay.
You don't trigger certain factors like FGF23, which you do when you give large doses. And large doses, intermittent doses, have been associated with increased rate of falling. Yes,
Achha.
yes. So the wheel is now turned around to small daily doses.
It increases the risk of falling.
Yes.
Sir, क्या hypothesis है, if I may digress?
There are lots of hypotheses. We can discuss that, but the risk of fall and risk of fracture. So it's not a 100% thing that it does, but at least 3 or 4 studies have shown that. So worldwide, the guidelines now, and we are modifying the Indian guidelines also soon, is to take small daily doses. But if someone can't do that, होता है ना कि डेली डोज तो लेंगे नहीं, कंप्लाइंस तो फिर मंथली दे दो, ऐसा नहीं कि नहीं दो.
राइट. सर, अब नेक्स्ट टॉपिक, आपकी नेक्स्ट स्पेशलिटी डायबिटीज. तो इसमें सर, फर्स्ट थिंग आई वुड लाइक टू आस्क इज व्हाट अ रेजिडेंट वांटेड टू आस्क यू. उसने बोला हिज फादर इज डायबिटिक, हिज मदर इज डायबिटिक, नाउ ही डजंट वांट डायबिटीज. कैन ही डिफीट जेनेटिक्स?
Well, you can definitely defeat genetics, I don't know, but you can certainly delay the onset of the condition.
Okay.
So diabetes is not just genes.
Right.
The prevalence of diabetes in Delhi at the moment, for example, would be almost 20%.
Okay.
I mean, if you took people at the age of 40, the prevalence would easily be about 20%. And if you went to 60, the prevalence would easily be 35-40%. 35-40% of people at the age of 60 have diabetes. So it can't just be the genes. Indian genes are not that bad that everyone should get diabetes. So it's a combination of family history and what you do with it. So as a very cliched sort of statement, that genes load the gun, but lifestyle pulls the trigger.
Wow.
Okay, so what happens is that if you're careful with your diet, with your exercise, maintaining your body weight, if you take that as the index, try to maintain ideal body weight, you can delay diabetes by decades. So that's the way it should be.
Sir, a lot of patients come with alternative medicines for diabetes. They take alternative medicines. Can diabetes be reversed, as a lot of people on social media are claiming?
So there are 2 parts to the question. One is about alternative medicines. I am a skeptic. I'm an evidence-based person. That's how we have been trained.
Right.
Unless I see the evidence for any drug being effective in a double-blind, randomized clinical trial, I will not use it. I can't stop people from using it, but I will not use it. So none of our preparations that are so popular have undergone this. And we cannot get away by saying that that's what is, they've been there for centuries, that's why they are good. So many things have been there for centuries and they're not good. Okay? That is no qualification. And similarly, a stupid example is that is natural, so it can't be. I mean, you're not aware of natural poisonous berries? Aren't you aware of things in nature that are so poisonous? So just by being natural or just by being old, it does not make it safe. I need a randomized clinical trial. Any molecule that shows that, I'm willing to try it on my patients. Randomized clinical trial showing benefit.
Significant, yes, sir.
So that is evidence. So I can't object to anyone doing what they want, but I don't believe in alternate remedies at the moment, at least, because at the moment we don't have any evidence, clear evidence that they work. Right? You would always someone get up and say that, oh, they worked in my father, they worked in his sister. That's all right. I'm not denying. Do what you like. At the same time, one is whether they work or not. At the same time, some of the therapies you consider completely innocuous, like Giloy was used a lot during COVID, but we know that liver damage after Giloy was documented. So we don't know their side effects also. For Western medication or modern medicine, every side effect is reported in clinical trials.
And is continuously reported,
And
even
reported.
now.
And one event can change the future of the drug. So because we know, we think they have side effects. And where we don't know, we are happy to say kuch nahi hai. So that is one thing. So the second part of your question was, can diabetes be reversed?
Right.
So yes, diabetes can be reversed in some people in the earlier stages. First few years of diabetes, young patient, especially if obese, an attempt can be made to reverse diabetes. If it is mild, then you can work only with lifestyle. If it is severe diabetes, you initially give medication, help the patient to lose weight, and then maybe he'll reverse it. But you cannot promise it. So all these advertisements saying we will reverse your diabetes, and some even say 72 hours and all that nonsense, that's all bunkum. But so many of our patients have reversed. Young patients. There's nothing new in that.
Sir, ये screening के लिए what do you think should be used? The HbA1c is one tool, and then there is always mean blood glucose also written alongside.
Yes.
Sir, I personally want to know more about it.
So for screening, you could typically do a fasting glucose, and you could do an HbA1c. I think that all people above 25 in India should be screened annually, all.
Using either of these things?
Yeah, I mean, I would say if you can, then A1C is good, despite there are fallacies with everything. But a fasting blood glucose and A1C combination is pretty good.
Okay.
Yes, A1C reflects mean glucose, that's all. It's a calculated value, mean glucose, based on the A1C. So, yes, HbA1c, if you have a value of 5.7 or above, then you say it's diabetes. Pre-diabetes. If you go above 6.5, you call it diabetes. So there are standard criteria. But screening is very important.
Sir, another question that comes from me. Sir, diabetes is so closely related to bone fragility, and that you have also showed multiple times. Sir, what all other orthopedic problems can be caused and how to deal with it?
So for a long time, we did not connect diabetes with bones really. Only in the last decade or so, there has been serious work in that. I'm part of that task force.
Right.
So the basic thing is that people with type 2 diabetes tend to have about 1.5 to 2 times, depending on the study you're looking at, greater fracture risk, which is a lot. And therefore, bone health evaluation of people with diabetes is very important. Diabetes may not affect the bone density so much as it affects the bone quality.
Okay.
So you got to be careful in interpretation of bone density. That's a separate subject. You take a little lower threshold, and even at -2 T-score in people with diabetes, you need to intervene.
Okay.
So there are a lot of nuances there, but there is no doubt that people with diabetes are at greater risk of fracture. They need assessment for their bone health in the same way as they need assessment for the eye, for the kidney, now for the liver. Fatty liver is another big area, also an area of my interest, and of course for osteoporosis. So all those, at least all those above 60 with diabetes should have a bone density done and talk to their doctor.
Sir, what does a typical day look like in life of Dr. Ambrish Mithal?
A typical day in my life, typically I would like to go for a walk in the morning. I do it at least 5 days a week. I'm an early riser. I leave home at 8:15. I start my outpatients at around 9:15.
Okay.
And the outpatient clinic in the hospital goes till around 5 straight. 4:35, right? Then I like to sit with my DNB students, and any challenging cases, any issues, any abstract, any paper, anything like that. And then I go to the ward.
So, कितने बज गए already?
So I leave work at around 7:15ish.
Okay.
7:15, but it's very controlled now for me because because I had a unit, because I'm so senior. Earlier on, it was always very difficult to control my own time. But now I have a big team that looks after the ward. I don't get calls at odd hours, but till about 10 years ago, I was doing that all the time. Even in odd hours, getting blood glucose values from the ward, the phone ringing constantly.
Right.
The phone still rings constantly, but that is because A, I answer all calls.
Great.
B, I answer all WhatsApp messages.
Wow, that's true.
And all my patients who want to remain connected, I don't give them my number, but if someone does find out, send a message, I will respond to something. I might say, no, come and see me tomorrow. I don't like giving WhatsApp advice, medical advice, but it's a big challenge because people pester you a lot.
You actually have a research paper on telemedicine, I read.
Yes, because in COVID we did the maximum telemedicine consults in the whole Mac system. So we wrote a paper on chronic care. So I think it's I also used to have a private clinic after that, which I stopped during COVID. So, and then I didn't restart because I thought it's causing me too much physical stress and mental stress and strain. So I took a call at some financial loss to stop evening clinics.
Okay.
But I'm quite happy with what I'm doing, which is what matters.
So, sir, what was the starting salary for you? And maybe it would be better to ask, what is the usual starting salary for an endocrinologist?
So let me first answer your first question. The first starting salary in SGPG, I don't remember. It was too small to remember.
Okay.
But it was there. We managed because we had a house and everything was okay. We managed. And my wife was also working, so we managed. The first starting salary in Apollo was 0 because it was just fee for service. Yeah.
Oh, okay.
Yeah. Okay. So first month I earned 14,000 rupees, which was exactly the rental of my flat in Vasant. Okay. So I had to borrow money from a friend in Lucknow to survive 3 months. But then things gradually picked up. So I think salary concept in private is very recent. It's not been there forever.
Okay.
So, people now, of course, are getting... I mean, it varies a lot between specialties and immediately after DM, etc., etc. I can't really say because it keeps going up a little bit. But if you're going to join a job in a corporate hospital and you're going to start off and you're a fresh DM, so anywhere between 2 and 3 would be a good starting point. Even 2 lakhs people start off with. I don't see any problem because it goes up very fast. Okay. But you should, if you're getting an offer of 2 lakhs in a corporate sector, immediately after DM, like without having worked anywhere, you will quickly go up the ladder. If you're getting it higher, 250, maybe now even 3, that's good. Smaller towns will give you higher salaries in the beginning.
Okay.
Because they have no endocrinologist and they want one endocrinologist to look after their whole hospital.
Right,
They'll easily give you 5 lakhs or something. But it plateaus quickly.
Okay.
But in a bigger canvas, you start with a lower salary and then ultimately you can end up much higher.
Okay. And sir, when we talk about salary, do you feel some specialties, especially the medicinal specialties like endocrinology, have definitely lower possibilities of income compared to, let's say, cardiology or surgical specialties?
So you're absolutely right. There's no doubt that specialties like endocrinology or internal medicine have less earning capacity than surgical specialties or even interventional specialties. So there are pros and cons to specialties like this. So, for example, for endocrinology, that's one specialty now in India where there'll never be a dearth of patients.
Absolutely. Diabetes capital of...
Number one, you will not have dearth of patients. Diabetes, thyroid, osteoporosis, something or the other, PCO, fatty liver even, that also is an overlap area. So there will be no dearth of patients. So you are quite comfortable that in 3 years you will have enough patients, which will keep you busy and you will earn a decent amount. So the second thing about endocrinology is that you're not dependent on a hospital. Your investment is primarily in your clinic. You don't have to buy a robot. You don't have to buy a, fancy equipment and nothing. Little bit here and there and you're set to go. So that is the advantage of endocrinology. The disadvantage is that you can never reach the financials. Like if you're a top endocrinologist, you can never be comparable to a top orthopedic surgeon. Okay? A top endocrinologist financially will be comparable to a mid-level orthopedic surgeon. Okay? That's the nature of the job. So you have to take a call on what you like to do. And so you cannot be frustrated by your surgical colleague earning much more or your cardio, because they will. Your cardiologist colleague also at the top earning much more. But you get a quicker start. And there are, as I said, you don't have often don't have life-saving emergencies. There's less litigation.
That's a good point.
Yes. So all those things are there. But it's a 24/7 job. So those who think endocrinology is a light OPD specialty, no. If you want to succeed in endocrinology, you have to be available to your patients all the time.
So there is less job saturation, there is low investment,
yes,
and litigation is very low.
Yes.
So these three are big points, I would say.
I hope I don't get a suit filed against me tomorrow. I'm just saying, so far endocrinology litigation has been very low.
And sir, as you said, you can put your own clinic, but then how did you and why did you choose to be in a corporate setup like this big hospital?
Yes, this is a question that most young endocrinologists ask me. Should I go for my own clinic? Should I go for the hospital? It depends on your mindset, what you enjoy. I can answer only about myself. I enjoy working in a team, enjoy having lots of youngsters around me, or when I was young, having senior people around me. I enjoy discussing cases. I enjoy seeing multi-specialty difficult cases. That is my sustenance. Otherwise, type 2 diabetes day in and day out can drive you crazy here. I like working in environments where all facilities are available. I need a good neurosurgeon is there, I need a good pancreatic, I need a good orthopedic, they're all there. So different specialties to back up my endocrinology is what I want to work in. Now, so that is the advantage.
That definitely means better patient care also.
I think so.
Yes.
I think it means better patient care for the most, especially because there is more than one mind working on every case. Like every Thursday, every Wednesday, all of us sit together and discuss the difficult cases. Someone has an input, someone finds a research paper, residents will find some answer. So I find that very fulfilling. It's an old teaching school habit, I don't know, but that's how I like to work.
Yes,
I don't envision myself sitting from 9 to 5 in a clinic or 9 to 7 in a clinic, just seeing, type 2 diabetes, this, that. But there are others who enjoy that. And undoubtedly, the financial returns from sitting in your own clinic, for the most part, unless you're at the very top of the pyramid, will be better than practicing in a hospital.
Okay.
Yes. Because there'll be hospital share. There'll be other things. If you're employing staff, there also ultimately in every corporate hospital, you are getting paid what you generate.
Part of it.
I mean, you cannot. So when people say, oh, I will never go to corporate hospital, there is so much pressure to generate income. There is so much, people, I hear that all the time. I have not met anybody who's facing that though.
Okay.
If you are saying, let's say, you're seeing 10 patients a day and you're earning 1,000 rupees a day, theoretically, okay? And you earn 30,000 rupees a month or 25,000 rupees a month, but you're taking a salary from the hospital, which is 1 lakh rupees a month. So there'll be a problem. At some point, it'll catch up. So if your salary is commensurate to what you can actually earn,
and there's no pressure.
There's no pressure. So all this talk about pressure is कि 6 महीने में परेशान हो गए, पहले तो ये दिया, वो दिया. So when you take the offer, you please have a realistic estimate of what you can actually earn. Most of the problems I found are related to this, because remember, ultimately this is a corporate hospital. They will not do anything at a loss. Why would they? Why would this? Common sense, right? So I'm not, saying that it's the best model or thing, but this is the model right now. So when you get into a corporate, you have the advantages. One big advantage of working in a hospital is that when you travel, when you have a commitment, I'm sitting with you and we are talking for last 1 hour. So what is happening to my patients? There's enough people looking after them. My colleagues are looking after them. So when they are busy, I'm looking after their patients. So this doesn't happen. In your clinic, you're gone. That those 3 days are gone. Those 4 days are gone. Those few hours are gone. So it's so in my way of thinking, this suits me better. But there are other very smart young endocrinologists, young doctors who prefer their own clinic, so that's fine.
Sir, doctor-patient relationship, इसके बारे में sir कुछ advices चाहिए.
I think doctor-patient relationship is the key to success. If there are two doctors, let's say two endocrinologists, both equally qualified, equally skilled in their decision making, but one person is empathetic, understands the patient's problem, and seems to be on the patient's side, not across the table, not confrontational. You're on the same side. You will get much better results, especially in chronic care. 2 ways you'll get better results. Number one, the patient will comply with your medication better if he trusts you. Second, in a more sort of practice sense, he will get his family to you, then he'll get his neighbors to you, then he'll get his whole colony to you, then he's coming from a small town, he might get the whole town to you. So how do you do that? One line formula.
Okay.
You place yourself in the patient's position. So if there's an 85-year-old man sitting across and he can't hear properly and he can't take off his shoes properly and you have to help him to do that and you're getting frustrated because there are the long queue outside, think if it was your father. How would you want the doctor to deal with him? That's it. Put yourself or your immediate family in that position, you'll never make a mistake.
Right. Even when there's a long list of patients and...
Yes, you still have to do it. You may find some way कि अभी आपका ये कर देते हैं, come back at this time, whatever. But you have to have that empathy. The patient should feel that you're concerned about him or her.
And not just some written
and not
piece
just
of
you're
advice.
not rushing him out. You may still spend the same time, but that vibe has to go to the patient. Right. And patients will do all kinds of, they may irritate you a lot at times. We have all kinds of people, like we have all kinds of patients, all kinds of doctors. So patients can be very unreasonable, especially in a paid environment. So everyone has their own formula of dealing with it. Some surgeons I know will just throw them out, get out, Yes. In my way of looking at it, I have managed not to get angry at any patient. If the patient is being particularly obnoxious, you say, it's okay, it doesn't matter. We'll arrange for you to see somebody else. I care for you, but I don't think that we can treat you like this. That is the worst I've gone to.
Okay.
I have never said, get lost. I've never said, because the reason is, number one, the person is very stressed. He is under a lot of, medical. Who knows, he's worried about his son's admission, about his father's hernia surgery, and he's actually coming for his own diabetes. He may have 100 things about his boss, about his loans. And we are going on saying your A1C is 7.1, 7.1, you have to bring it to 7. So patient can be rude. So you have to, of course, you should not see anybody who's spoiling your day. But the fact is that we should not utter things that can be construed as being rude. Because what happens is, what the patient said for 20 minutes before that is not recorded. What you said will be framed and broadcast all over the city.
absolutely.
So I think patient relationship is very important. Empathy with the patient is very important.
Communication.
And patience for the doctor is very, very important. Both patients and patients. Okay?
Yes, sir. Sir, this was a great advice, but any general advice you would like to give the young medicos, people who are in the final years of MBBS and thinking about careers?
So I think those who want to be in this profession, I think should have two attributes. Number one, they should have a passion for the profession itself. They should enjoy, as I've said earlier, they should enjoy the process. They should enjoy medicine. Otherwise, there's no point. Because if you're doing it as you do a finance job or a lawyer's job, it's not the same. Okay? Number one. Number two is that they should like people. If you don't like people and interacting with people, you may be a very good clinician basic scientist, but you will be very hard pressed to deal with the numbers of people you have to deal in this country. So if human interaction causes you stress, and there's nothing wrong, there are people who don't like human interaction too much, you will forever be stressed. So in my understanding, especially for physicians, but for surgeons also, you have to be a people's person. You have to like meeting people. I think the biggest thing in my profession has been the kind of people I meet. It's fascinating. Every day I see so many different kinds of, learn so many different kinds of things, see so many different kinds of professions. I learn about professions, regions, habits, psychology. So you have to enjoy that part. Otherwise it's difficult.
Sir, when you talk about patient relationship and building communication, sir, how far or how deep do you go into the history apart from the general complaints and about the disease they have? Then to build relations, I'm sure you must be asking more questions.
So yes, so it is not possible. We have to strike a pragmatic balance. So the moment my numbers increased, I hired a doctor. When they increased more, I hired a second doctor. When they increased further, I had a third doctor. So the time is spent with my team more, and they'll give me a summary. Inka wo bhi problem chal raha hai. She just lost her husband, sir. That's why she's so upset. So I get that feedback for some of them. For some, I do it directly. But it is not possible to do the numbers that we are expected to do in this profession and get into the patient's problems. Exactly. So you can you have to sacrifice something. You have to sacrifice your income. If you're hiring more people to look after the number of patients that you have, you're sacrificing your income. If you do it faster and faster, you can see more patients, earn more money. So that's your call.
Sir, ये chronic diseases के patients आते हैं आपके पास. What kind of psychological issues or mental health issues creep up with these chronic diseases, and how do you deal with them?
So I think there are two aspects to this. One is that diseases themselves can cause mental health issues. Hypothyroidism can cause its own issues. Hyper causes its own issues.
Right.
There are direct links of hormones with mental health. Menopause. All those things can cause their own. So that is one aspect. The other is just the burden of chronic disease.
Exactly.
And that causes significant, depression and so many things. So I don't think you can be a successful physician for chronic care or an endocrinologist or whoever is looking after patients who require chronic care unless you're a good psychologist. And many a time the medical decision takes 30 seconds. You have to increase or decrease the thyroxine dose or the oral antidiabetic dose. But the explanation and convincing is what differentiates the more successful doctors from the less successful doctors. And my secretary sometimes jokingly says, आपका सारा काम तो आपकी टीम करती है, आप तो खाली endocrine psychiatrist हैं. So that's a very important part. That ensures compliance, adherence, and gives better results.
Right.
So I think we cannot run away from that responsibility. So we have to deal with different patients very differently with the same condition.
So now some questions, if you can answer them in one word or one short line, that would be nice. What is the most surprising or unexpected question a patient has asked you?
So one patient asked me, what do you yourself eat? You're advising me all the time. Today I'm going to stay and see what you're going to have for lunch.
Nice.
आज डॉक्टर साहब मैं देख के जाऊंगा आपकी, ये मेरी जिंदगी मेरी बीवी ने खराब कर रखी है, ये मत खाओ वो मत खाओ, बोला डॉक्टर ने, आप क्या खाते हैं मैं देखना चाहता हूँ.
और उस दिन आप छोले भटूरे लाए नहीं?
लंच इज ऑल फिक्स्ड एंड देयर वाज नो पार्टी दैट डे. पार्टी में बहुत गड़बड़ होता है, डिपार्टमेंट पार्टी होती है, हफ्ते में एक बार तो हो ही जाती है. बट सो आई रियली हैड अ गुड लाफ एंड आई ओपन माय टिफिन एंड शोड हिम. इतना ही खाते हैं आप लंच पे? हमने कहा यार टाइम नहीं होता तो क्या करें. तो सो दैट वाज वेरी अनएक्सपेक्टेड.
So if you hadn't chosen endocrinology, what else would you be doing today?
So if I hadn't chosen medicine, I would probably have been a journalist or a historian.
Okay. Okay.
If I hadn't chosen endocrinology, I would have chosen some other medical specialty, because during my internship, my psychomotor skills were classified as poor. My motor skills rather, not psychomotor, motor skills. And my seniors told me, तुम पढ़ने लिखने वाले आदमी हो, मेडिसिन में जाओ, इस सर्जरी तुम्हारे बस का नहीं है. So I quickly dropped the idea of going into any surgical discipline. I'm not so skilled that I could be a very good surgeon. I could be an average surgeon, I suppose, but I chose this. Yeah.
Good for us, sir. Sir, 30-40 years in endocrinology.
Yes.
What is the future of endocrinology, let's say in 2050 or...
So I think endocrinology has really exploded. It's a specialty that when I joined endocrinology, I was told that it has no patients and it is only an academic specialty. This was what my professor told my mother.
Okay,
1984. But I think endocrinology has exploded and will continue to explode. The connections, the fact that hormones control almost everything at different levels, and the ability to measure hormones accurately, measure different kinds of substances accurately, and the fact that we can combine it with genome testing now. I think genomics and this is going to change our approach to endocrinology completely. And it's only going to explode more and more. I mean, it's really going to grow. And by 2050, I expect that we'll have a completely different approach to endocrinology than the traditional one that we were brought up on. There's 7 ductless glands and all that, you know. It won't be like that. Yeah.
Sir, AI bhi aa raha hai. Is AI coming into it?
Yes, of course. AI will definitely have a role in many ways, and we can discuss that separately. But it will have a role in, for example, in diseases that affect large segments of the population, diabetes.
Okay.
So we are still using same drugs for everybody almost, with some modification. AI will give us the power to analyze that data, do the number crunching, figure out which drugs work for whom better in like millions of patients, not like few hundred. So that is one example. But in drug discovery, in endocrinology, you know, the AI will have immense potential in endocrinology, like in other fields of medicine.
So multiple awards, so many publications, famous name in endocrinology. Sir, how exactly would you like to be remembered as?
I haven't thought about it because I'm still quite active. but yes, I would want to be thought of as someone who was sincere and committed to his job and did the best he could for everybody that, you know, that came in contact with him, whether it was peers, whether it was students, whether it was patients. And I mean, I would like to be known as someone who tried his best.
Well said, sir. Great answer. So, thank you, sir. Thank you for coming on this podcast.
You're welcome. I quite enjoyed the discussion. So let's see how it turns out when you finally play it or post it.
Yes, sir.